Because it's important for you guys to see it afterwards, isn't it? Okay, sorry. So we were saying that it's a constellation of disorders which tends up in AVN. The most important reason for this is vascular supply of the bone is deprived. Because of that, it causes problem. Also, when the blood supply to the bone is not proper, the cartilage itself is avascular, and therefore blood cannot come from the cartilage to the bone. And most of the bone joints have got N artery supplied, which means they are not an anastomosis, but they are N arterioles, which means if that gets blocked, then nothing else will come and help it. Okay, clear?
Clear, sir.
So what,
yes,
what can cause? You did give me some reasons. And there are vascular occlusion because of trauma, because of stress fractures, because of some reason where the blood flow is slow, or when you have sickle cell disease. Pakistan will have a lot of sickle cell, and that's why you may see a lot of AVN in the hips purely because it's related to sickle cell. So if you have a long case with AVN, don't forget to ask, does the patient have sickle cell trait or disease? Okay?
Right, clear.
Pakistan has sickle cell quite a lot, isn't it?
Yes, sir. We often see sickle cell patients here, sir.
Yes. So if you see a patient who has a long case for you as AVN, then do ask sickle cell trait, because that may be the reason why the patient is. So you may do a very good exam and a very good examination, but forget to ask the patient has sickle cell disease. Okay. Then you told me there were hypocoagulable states which causes it. And the commonest cause in this country is alcohol and steroids. I'm sure you have steroids also in your country as a problem for AVN. And in our part of the world, transplant patients are another major cause. They have a lot of steroids given them to suppress immunity, and they have problems. Okay?
Okay.
So you have to have a minimum of 12 hours of relative blood flow loss or anoxia for the bone to start necrosis. So the key factor is that the insult should be longer than 12 hours. So if you have trauma, then the insult is longer than 12 hours because the blood supply is gone. If you have dislocation, if you reduce within time, you may recuperate your blood supply. If you have deposition disease such as Gaucher's and Verus, all these other coagulopathies, then the deprivation is also longer. So it is a chronic condition, but you have to have a minimum of 12 hours before it can take place. After you have anoxia, then you have a bone reaction to the dead tissue and dead bone. Okay, so remember, the bone can only understand one language. Whatever happens to it, it thinks it's broken and wants to make new bone. Okay, the next stage of this is that once you have lack of blood supply and you have a reaction for new bone formation, do you know what happens in new bone formation? The first thing is the macrophages will come and eat up the dead bone, isn't it? So what would that look like on X-ray?
Sir, some area of rarefaction on the X-ray?
Yes, it will look like the fracture is increased, or there is a big cavity or cyst formation, because the macrophages are coming to clear up the debris, like I said. So there is no bone in there, therefore it will look like a cyst. Then the granulation tissue starts coming across the necrosis bone, which will look at like a sclerosis in X-ray. At some stage, the bone structure will fail and the head will no longer be round, and then you have collapse, which ends up with various other changes from it onto X-rays. Okay, so do all people have AVN? So if you're older, will you have AVN? If you're a 70-year-old, will you have AVN?
Not necessarily.
Why?
Sir, because there may be some blood supply from the teres, that ligamentum teres, sir.
Yeah, I know, but the blood supply is there in a 40-year-old. So, but if you're a 40-year-old, you will have AVN if you have a problem. If you are 65 to 70-year-olds or an older population, you don't have AVN. And the reason for that is you need to have a fatty marrow. Okay, a fatty marrow should be you to have AVN. In the older people, the fat cells become smaller. Okay, so the fatty marrow becomes smaller. So that marrow is then called gelatinous marrow, and gelatinous marrow will have profusion of blood from all around it. So older people don't have AVN. It's only young people who have AVN. Okay, and you have to have a fatty marrow to have AVN. If you don't have a fatty marrow, you can't have AVN. That's a prerequisite for AVN around various joints. Do you get that? So older people don't have AVN. It's the young people who have AVN. So if you have a neck of okay?
Yes, sir.
So we've already discussed this, but this is just to look at it again, right? So we are looking at the etiology of it, and obviously you know all of these, but you have to remember this, and there must be a mnemonics for you to remember this. But the easiest thing to understand is it is trauma. Trauma is number one, and steroid and alcohol abuse. Okay, some of the collagen disorders, sickle cell in hematology and hemoglobinopathies. So sickle cell in Pakistan must be the commonest problem. There are some metabolic conditions, and you have certain conditions which are orthopedic disorders which will eventually lead to AVN. And we've all talked about Sufi and developmental dysplasias and Perthes disease and all that kind of stuff. Okay, before I forget, how do you differentiate between Perthes disease and something else? How would you confirm a diagnosis even if the X-ray doesn't look bad? Do you know the
Audio gone.
Sorry?
Sir, I could not hear you, sir.
Sorry. Okay.
How would I differentiate between
how do you
Perthes
confirm a diagnosis of Perthes disease in early stages when there is not much to see?
Sir, there are signs of subluxation and all that.
Sir, we will go for. Sir, I think we will go for MRI. If we could not see anything
that's
in
not clinic. Yeah, I remember I told you this. You guys don't remember what I tell you. What you need to do is bone age the patient, and then his chronological age will not match his bone age.
Yes, sir.
That is a confirmation diagnosis of Perthes disease, and the reason for that is they have some sort of collagen disorder because of Perthes disease that causes them to grow slow. So the bone age will not match their chronological age. So if they're 10 years old, the bone age will be 8 or 7 or something like that. Okay, so that's a confirmed test for doing Perthes disease. Do you remember the name of the atlas?
Sir, can you repeat this again, sir, please?
Okay, so if you are a child who's got hip pain, but you suspect Perthes, but there are no MRI features or no CT scan features or X-ray signs, to confirm the diagnosis of Perthes disease or to exclude the diagnosis of Perthes disease, you have to do bone age of the patient's left hand. And you have an atlas, it's called the Brulich Pile Atlas. It will tell you what the age of the patient is by looking at the X-ray. So once you look at the X-ray, if the X-ray tells you the patient is 8 years old, however, the patient is 10 or 9 or 11 years old, is older than the age of the X-ray of the hand, and that is a sure sign of Perthes disease. Because of some sort of collagen disorder, the age does not match their chronological age. Okay, so we've talked about trauma, we've talked about steroid and alcohol abuse, we've talked about some blood disorders. You must not forget sickle cell if you're in Pakistan. Metabolic disorders, some orthopedic preconditions such as Sufis and Perthes and various other things. People with infection. In UK, the commonest cause is HIV, but in Pakistan, it must be osteomyelitis. So we have renal transplants, but these are people who take a lot of steroids to suppress their immunity so that the kidneys can start. And then some tumors and pregnancy may or may not cause AVN, but bisphosphonates usually does. Okay, and remember Casson's disease, which is where you go into high pressure and you come out swiftly and you get bubbling, and the bubbling causes clotting or clogging or coagulopathy of the vessels, and therefore they have AVN. So will everybody remember this? You don't have to know all of them, but you need to have enough to satisfy the examiner. So always start with trauma, steroids, alcohol abuse, blood disorders, connective tissue disorders, old orthopedic infections, transplants, and Casson's disease. And don't forget malignancy. Lots of malignancy do throw emboli, and these emboli go and clog blood vessels and cause problems. Okay.
Is smoking related to AVN?
Don't know, but smoking causes sluggishness of your flow in your vessels. So by causing slow flow, it may cause an increased hypercoagulability, and therefore, because of hypercoagulability, it may cause some sort of thrombophilia or something like that. May cause AVN. So there is no direct correlation, but indirectly it may cause AVN.
Sir, I have a question, sir.
Yeah.
Excuse me, sir?
Yeah.
Sir, you said that bisphosphonate is the cause of, maybe the cause of AVN. But in the bisphosphonate, sir, regarding bisphosphonate use.
Yes.
Then, sir, why it is advised in the first stages of in the first stages of AVN, bisphosphonate is advised, sir.
Okay, so when you have bisphosphonate not as a cause of AVN, what bisphosphonate does is increases the stability and decreases the fatty bits of the bone. You know, the more bone marrow, if it is fatty, then it will cause AVN. But by decreasing the fat in the bone marrow, making it less fatty bone marrow, it will help the pain relief and restructure the AVN. However, if bisphosphonate is causing AVN, then you should not give them bisphosphonate.
How will we rule out this, sir?
In history, it will tell you that you've been doing bisphosphonates. If you give the patient bisphosphonate, and it has to be more than 5 years of bisphosphonate before it causes AVN.
Okay.
So one more thing. You know, I keep remembering things, and I want you guys to remember because the time is short. So if you have got a pathological fracture of, say, the humerus, right, and you want to nail it, what precaution will you do to stop embolizing and causing infiltration and malignant emboli to go into the body?
Which fracture, sir?
So if you have a pathological fracture of the humerus, okay?
Fix it, sir.
No, I don't want you to tell me how to fix it. I want you to tell me that if you have got a pathological fracture of the humerus, yeah, and you have decided to nail it, what precaution you must do? What precaution?
Unrimmed nail. Yes.
No. Even if you put a rod in it, it will cause emboli. So what precautions will you have to do in a pathological fracture to stop embolization?
When you reaming it and you putting a nail, you should give an high oxygen to the patient and keep the blood pressure at normal levels.
How many times is an anesthetist listen to what you tell him? Never. You can't tell him, oh, iska oxygen kam karo, iska blood flow zyada karna hai, aur ye wo. No.
That's for SLE.
Sorry?
What Sama is telling is for SLE. So if you have a second,
what you have to do is you make a window distally. So you make a distally. If you make a window distally, the pressure will not increase, and therefore you'll be able to safely put an intermedullary device. So in a pathological fracture, whenever you're putting an intermedullary device, you have to make a window so the pressure does not rise for it to embolize. Because if it embolizes, the next thing it will be in the lung, and then you'll have secondaries in the lung, and the patient can die from it.
So window is already made in the entry of the nail. So why putting a window another?
Window in the bone, so the pressure when you push the nail down comes out of the bone rather than stays in the bone. So you vent it. This is called venting a bone. In our practice, what we do is we put a nasogastric tube, you know, the child pediatric one. We make a window in the bottom of the humerus, and we put one of those to allow the pressure to come out of it, so that it is not high enough for it to embolize. It's all written in the books. You guys are not reading books. You're just preparing for exams for nothing at all. You must go and read also. Well, it's too late now. It's about 2 weeks still, but you must pray now.
1 week, sir, not 2 weeks.
No, okay, 1 week. So even less now. See, there's no chance in reading books anymore. Okay. You know, bisphosphonates causes stress fractures, and it causes a lot of problems, but it only causes it if you give them for longer than 5 years. So the current recommendation is you give them 3 years, have a break of a year, and then start again. Okay. So what happens in trauma? The blood supply goes in a displaced neck or femur fracture, okay, or such as other small bones. And because of that, there is local osteonecrosis on the convex surface of these bones, okay? It is called osteochondrosis. It is not infection, but osteochondrosis or blood supply. So if you look at it, what happens is this can be anything, okay? But what it does is either the blood supply is gone or blocked. You have marrow edema. Again, remember, you have to have a fat edema to cause AVN. If you don't have fat bone marrow, you can't have a marrow edema. This causes sinusoidal compression. This causes vascular stasis, and the blood vessel is closed. So you can have sickle cell, you can have Gaucher's disease, you can have trauma, you can have Casson's disease. All these is the same pathway. What happens is either the blood supply is closed or discontinued or blocked. Because of that, you have marrow edema. The marrow edema then causes sinuses to compress. Because of that, you have vascular stasis, and that causes more compression, and then the blood supply is deprived and it dies. Okay, so remember, this is a cycle that can fit into anything. How do they present? Do you know how do they present? Slides in front of you. You can read it off it, or you can tell me.
Necrotic pain, sir.
They come with either a history of trauma, okay, or they will tell you that they were using steroids because they had a transplant, or they were having some condition where the GP or the physicians were giving them steroids. Occasionally, you will get somebody who will give you a history of alcohol intake. However, some of them will plain tell you that I have a tumor, or I have a blood disorder, I have coagulopathy, I have a sickle cell disease, or I have SLE, right? Do you see SLE in Pakistan? I remember seeing one patient in all my house job duration of SLE, but is there SLE in Pakistan? You don't see SLE. Okay. So they will give you a history of pain, and pain is actually gradually getting worse. Okay. Occasionally in the late stages, when you see them, then you have deformity because the joint has gone all pear-shaped, and therefore it is not normal anymore. So remember, in the history, do a good history, take a history of trauma, steroid abuse, alcohol abuse, medical condition, and progressiveness of the disorder, and where the deformity is now. Okay. If it's a hip, they will come with a limp. They will have an antalgic gait. Do you remember we talked about antalgic gait? What's an antalgic gait? Why has everybody gone quiet? Everybody's gone quiet. What is an antalgic gait? Can you guys hear me? Hello? Have I lost you all?